registered physiotherapist. Today I'd like to talk to you a little bit about herniated disc in the lumbar spine and what can be done about it from a conservative perspective or from a physiotherapy perspective. So first of all, I just want to talk to you about sort of the mechanism of injury and what typically occurs in a lot of cases with a herniated disc. So essentially your spine is made up of different vertebrae. You've got your cervical, your thoracic, your lumbar spine, and your sacrum. And essentially, between these different vertebrae, you have these discs. And the discs, they more or less act as shock absorbers. And so within the disc, we have this jelly-like substance that can actually protrude out when we have this herniation in a disc. So a lot of times the way I like to think about it is kind of similar to almost like a jelly donut, right? So if I squeeze, right, the jelly donut on one end, some of that jelly material or disc-like material can start to protrude outwards. Now, what can happen with a herniated disc is there's also, they're called nerve roots, right, that come out of the spine. And what ends up happening is these nerve roots which come out, they form peripheral nerves which then run down the arms coming out of the cervical spine and run down the leg for essentially the nerve roots that come out of the lumbar spine. Now what can happen is, as a result of this disc herniation or some of this jelly-like substance coming out and protruding out of the disc, it can actually put direct pressure on one of these nerve roots, which then can actually form or produce these peripheral symptoms. So for example, people will complain about shooting pain or numbness or tingling down the leg into the buttock in a lot of cases, so that's referred to as sciatica. These symptoms can go all the way down to the toes. You can get a cramping type sensation. You can also actually get a weakness within certain muscle groups that are innervated with the particular nerve root that's got pressure on it. So the reason for this particular weakness is when there's a nerve root that's impinged, or again pressure as a result of some of this disc material putting pressure on the nerve root, the signal's not getting through. And so as a result of that, what ends up happening with these patients is we end up getting what's referred to as a fatigable weakness, in which as you sustain a contraction, you're not able to sustain it for a long period of time because again, that signal doesn't get through. The other thing too that you might see with somebody who's got a herniated disc with pressure on a particular nerve root is a term called listing. And what listing means is essentially when a patient comes in and they almost look like they've got a lateral curvature in their spine, or they kind of present almost like a scoliosis where they're basically listed off to the side like this. They come in walking like this. Now the reason for this is the body will automatically adapt to this pressure on the nerve root and will typically try and go away from where pain or discomfort is. So again, a lot of times individuals, not all the time, but a lot of times when individuals come in with a particular herniated disc, they'll actually, not only will they be getting these sort of symptoms down the leg, but they'll also be kind of listed off to the side, typically. And so the way that you want to treat this, again, from a conservative standpoint, is particularly if an individual comes in with a particular disc issue and they're presenting with these peripheral symptoms, right, so numbness, tingling, pain, shooting pain down the leg, is you want to centralize that pain. So this is a McKenzie concept essentially. And so again, the idea is we want to produce with repeated movements, we want to make sure that the symptoms of what's occurring for the individual is actually centralizing. What I mean by that is that the symptoms are moving up the leg into the source of the problem, which essentially is the lower back. Now, if somebody presents, if a patient presents also with a list, right, where they're kind of off to the side, we actually need to correct that first. And so there's different techniques that we'll use in terms of from a physiotherapy standpoint, in which the physiotherapist will actually repeat a specific movement, right, to correct that list. Now, in correcting that, what we have to make sure is that the symptoms don't peripheralize. And so what I mean by that is that they don't go further down the leg. So when you're correcting a list, essentially, you have to make sure that the symptoms are moving up the leg with the correction, and ideally moving into the back. If the symptoms don't do that, you want to not continue with the correction of that particular list. So that's step one, correction of the list, centralizing the pain. Then from there, you want to actually bias one position or the other in terms of what, again, continues to centralize the pain. So in a lot of cases with a herniated disc, extensions will actually improve the symptoms down the leg, and again, ideally centralize the pain. So again, going back to that kind of jelly donut analogy, so if I put pressure on one end of the jelly donut and the jelly comes out this side, well, if I put pressure on the opposite end, then the theory is, okay, I'm taking pressure again off of that nerve root. So the extensions, typically what they look like is we'll have a patient actually lying on their stomach, and they repeat basically like a sloppy push-up where the pelvis is staying down on the ground and you're just lifting from the lower, from the chest area. The other option too, and I'll sometimes combine this with a list correction, is a standing extension. And so what this looks like is essentially you'll have the patient place their hands on the top of the hip, and then just repeat extensions back in this position. And again, the idea is those symptoms, you want to make sure that they are centralizing, right? So that the symptoms are actually moving up the leg and going into the back area. If they're going further down the leg, we need to stop, right? That's sort of your red flag, so to speak, and you want to not continue to do that. So again, the idea with, from a conservative standpoint in terms of correcting or rehabbing a herniated disc is, number one, if there's a list, you want to correct the list, making sure that these symptoms centralize. You want to bias a particular position in which, again, the symptoms are centralizing. And then there's several other things that you want to do from a rehab standpoint in terms of avoidance of flexion typically, so prolonged sitting, etc. And also core strength, right? So a lot of times with these herniated discs, a lot of times it's caused by some sort of trauma, right? So an individual does, for example, a quick lift and a twist. Typically it's in a bent forward position. They might sort of rotate in a funny position. So you also want to work on some underlying core strength in order to protect and stabilize the back. From there, you'd also want to eventually, depending on the patient's activity level, is reintroduce whatever activity they've been perhaps avoiding as a result of this pain. So if there's a sport or working out, etc., you want to do that in a safe manner. Again, that doesn't reproduce any of those peripheral symptoms. If you have any specific questions or concerns, I'd love to hear. Please leave a comment below. And thanks for watching. And also, please make sure to talk to a physio or a doctor before performing any of these specific exercises. Thanks so much again for watching. Have a great day.